I shall discuss about how I approach newly diagnosed multiple myeloma patients. First of all, taking care of a newly diagnosed myeloma patient, we have to make sure that they are symptomatic myeloma that needs treatment. There has been some changes in the definition of high-risk asymptomatic myeloma, whereby we actually recommend starting treatment a little bit earlier than the classical CRAB symptoms, which is hypercalcemia, renal impairment, anemia, and lytic bone disease. So if a patient with asymptomatic myeloma or smoldering myeloma comes in now with greater than 60% plasma cell infiltration in the bone marrow, or kappa lambda ratio greater than 100 with free kappa or free lambda greater than 100 milligram per liter, those patients are also now considered patients who need to be treated. So these patients will start on treatment a little bit earlier, because the understanding is if you follow these patients, they all progress to myeloma within 2 years. So we feel it is not good to follow these patients till they end up with actual bone destruction or actual renal impairment. So typically we say we want to start treatment in patients with symptomatic myeloma, but I want to couch this new definition of high-risk asymptomatic myeloma who also warrant initiation of treatment. Now, how do you want to approach a patient with newly diagnosed myeloma patient? Generally, we do include high-dose therapy and stem cell transplant for the management of newly diagnosed myeloma patient. So this invariably allows us to categorize patients into patients who are potentially eligible to undergo high-dose therapy and stem cell transplant, and those elderly patients in whom we do not incorporate high-dose therapy and stem cell transplant in the management. And then if we take this elderly patient, we also now have a new definition of how to manage these patients. Those patients who are elderly but fit in terms of their performance, those who are not quite so fit, and then finally those who are frail, patients over the age of 80 years, those with a lot of comorbidities who would not be able to tolerate treatment as well. So there is a recommendation how to manage those patients also. Lenalidomide has been approved for newly diagnosed myeloma patient based on the first trial which was conducted. The first trial results are already out there in publication, but now lenalidomide has been officially approved to be used in the treatment of myeloma patient. I generally try to treat patients with 3-drug combination. The first trial has the approval for treating patients with 2 drugs, lenalidomide and dexamethasone. The choice of whether you use 3 drugs or 2 drugs could vary according to the region. Much more utilization of 3-drug combination in Northeast and the Pacific Coast, much more utilization of 2 drugs in the middle. Now I'll give you the rationale why I like 3-drug as opposed to 2-drug. The way we understand multiple myeloma now, we know even from the time of diagnosis there are 2 different pathways to develop myeloma. One is the patients with hyperdiploidy. That means these patients have multiple chromosomal acquisition, especially the odd chromosome. Then those are the patients who do not have hyperdiploidy or non-hyperdiploidy, quite often with translocations. That was okay, but now we realize that even in a single patient there are multiple clones, typically 3 to 5 clones even at the time of diagnosis when we are ready to treat. So with that in mind, I like to use a proteasome inhibitor, a immunomodulatory molecule, and a glucocorticoids, 3-drug combination. Thereby you are able to treat different clones in the patient much more effectively than you have been able to address with 2 drugs alone. That's why I prefer 3-drug combination as opposed to 2-drug. Now, is one better than the other? We do not have that answer right away in newly diagnosed myeloma patient, but there are several randomized trials which include lenalidomide dexamethasone with or without ixazomib, for instance, with or without elotuzumab, for instance, with or without daratumumab. So all these kind of trials or pivotal trials are coming along. But looking at relapsed multiple myeloma in the last ASH meeting, the ASPIRE trial was shown. That showed that if you combine lenalidomide dexamethasone with carfilzomib, you get greater mileage. So coming back to the newly diagnosed myeloma patient, I think now I feel comfortable saying that 3 drug is my standard of care for patient with newly diagnosed myeloma patient.